This is Dr. Weich Coleman, and this is video 6 of 7 in the Cataract Surgery Basics series. If you haven't seen the other ones, watch them first. So this is the portion of viscoelastic insertion to fill the bag, lens insertion, and removal of viscoelastic. So this is probably the simplest step in the whole series. I'll have a few pointers to give. Like the other videos, I'm not necessarily going to talk along with the videos that you're seeing. These are 10 random cases from a given surgery day. So they're a good representation of some variety. At the last 2 or so, I will talk as it's going, but otherwise, watch the videos and we'll talk about some general concepts, and I'll touch on them if they happen to come up in the video as we're talking. So, in general, one of the things that I learned from these videos is what the average time for each step is. And I was really surprised to find that lens insertion, viscoelastic removal takes about 1 minute and 20 seconds. Well, nucleus removal, which is the next longest segment, only takes about 1 minute and 30 seconds on average. So this is really a long time portion of the case comparatively. And I'm working on hydro implantation where we don't use viscoelastic. I've got a few videos up on that, and I think that may be the future of cataract surgery to speed it up a little bit. You know, shaving a whole minute off would be a powerful thing on the average. So, you know, I'm using Alcon SA60WF. This is in a C cartridge. This is a 2-4 wound. You know, injecting viscoelastic seems simple, but you want to make sure that you fill the capsular bag. And I see this with residents often where they just want to fill the anterior chamber and people tell them, don't point that visco cannula posterior because you're at risk of rupturing the bag. Well, it's important to remember that as long as you have flow coming out the tip, then you have viscoelastic that's pushing forward. You know, this is ProVisc, this is cohesive viscoelastic. As long as you have a fluid wave coming out the tip of the cannula pushing forward, you really can't hit the capsular bag unless you make some sort of dramatic movement. So I do like to go in and fill the anterior chamber a little bit, but then I want to point it posterior and really get the cannula inside the capsular bag because I want to create space in the capsular bag. I don't just want to push the anterior leaflet of the capsule back and create space in the anterior chamber or in the ciliary sulcus in this case. You know, if you're putting a lens in the sulcus, certainly you want to do the opposite. You want to go strategically put space and viscoelastic between the anterior capsular leaflet and the iris, but in this case, we don't really want any space there, and we definitely don't have a real utility in deepening the anterior chamber a lot because that's just going to make the space in the bag less. So when I'm putting viscoelastic in, I'm really making a point to create a little bit of space in the anterior chamber and fill the capsular bag. So this video is a specific example of one where I went through the paracentesis wound. Why did I do that? Well, it was because I saw a couple of little chunks of residual nucleus sitting at the paracentesis, and if you think you might see that, there's no reason not to inject the ProVisc through the paracentesis and get those two pieces moving so that they can be removed with the IA, and you don't have to come back and find out after you hydrate at the end that you've got a couple of small pieces of nucleus floating around in the anterior chamber. Then you have to come back with IA or burp them out. In any case, it's an extra step. So if you notice, see the nuclear fragment? If you notice a small nuclear fragment hanging around the paracentesis, which they commonly do, you can go ahead and just inject your ProVisc through the paracentesis, free them up, get them moving, and then you can remove them at the same time you remove viscoelastic. So once we've inflated the anterior chamber and then inflated some space into the capsular bag, you know, I use single-handed lens insertion. Some people will want to use a second instrument through the paracentesis to stabilize the eye. If you go bevel down, and on some lenses you have to go bevel down because they're so tight, going through a 2-4 incision or whichever size you use, you're going to have to stabilize with a conner, and you're going to have to go bevel down. But with an Alcon C cartridge through a 2-4 wound, which is what we're looking at here in all these cases, I can go bevel up. I don't need a second instrument to stabilize the eye. When I say stabilize, I truly mean not rotating it away from you, not rotating it nasally as you're injecting the lens. So you'll notice when I'm going into the main wound, I'm using some downforce to keep the eye from rotating nasally, and then I'm doing a lot of rotation. So I want to have that injector held in my fingertips where I'm able to rotate almost 180 degrees in both directions, because it's the rotational component that really allows it to slide smoothly through the wound. It's not just pressing. So pressing harder doesn't necessarily solve your problem. Rotating solves your problem if you're having trouble getting in your main wound. So remember to position it in your hand in such a way, and even if it takes both hands, that's fine, but be ready to get a lot of rotation, and that's going to reduce the amount of forward force that you have to put in to get the cartridge in the eye. Once you get it in the eye and start injecting, there's a natural tendency to pull back, and this is true with different lens platforms a little bit more than it is with the platform that I'm looking at here. I've been using some Zeiss CT Lucius 1621Ps lately, light adjustable lenses, and for whatever reason, they have more of a tendency to migrate out of the wound as you're injecting. So you have to really be focused on keeping it in the eye. I'm not a huge fan of a wound assist injection. I think that could be hard on the endothelium, and it's just not my technique. So I think there are people who have videos up that they do a great job of that. It's not my technique. I try to keep the cartridge fully in the eye as I'm injecting the IOL. So once you're in and you start injecting, you want to just make sure that the leading haptic is going into the capsular bag. Now you don't want to point it too posterior, because you could rupture the capsule bag with it, and I've done it before, and I've seen it happen with our fellows and residents. You can make too much of an effort to go posterior, and you really want to initially point posterior into the capsular bag, and as you're injecting further, you want to start flattening out. Once you can see the entire capsular bag moving slightly nasal, being pressed by the lens at the equator of the capsular bag, and it's dragging the whole bag slightly nasal, that's the time that you need to be pulling back on your whole injector and removing it from the eye, so that you don't stretch zonules and you don't distort the bag too much. I think it's possible to weaken zonules in that case. One of the things that we've noticed is we don't like to load our lenses too soon before we use them. In the cold OR, it takes them a long time to unfold. If you can load them probably within just like about 5 minutes of when you put them in the eye, that tends to be better. Some people warm them up. Some people put them under their arms, under their shirts, whatever. All those things work. Generally, if they're cold, they take a little bit longer to unfold, and I think they're a little bit more likely to scratch also. So at about 100 cases, that's when I say that a resident should probably be going behind the lens to remove the viscoelastic. It's important to remember that that's not a necessary component of the case. If you have a very difficult case or a very difficult patient, you really don't have to go behind the lens. I think it's optional, but I think, especially in the case of toric lenses, if you leave Provisc in the posterior chamber, or in the posterior behind the lens in front of the posterior capsule, it creates a pivot point that probably makes rotation post-op more likely. So I think it's really critically important in the case of a toric lens. Otherwise, maybe not that important, probably reduces your risk of a post-op pressure spike to go ahead and get it out. But I think it should be routine by about case 100. So I'd be disciplined in your training to try to go ahead and be getting behind it. And I think of it as just nudging the lens out of the way. Now, you want to have the haptics positioned in such a way that it's easy to get around the lens. Now, I'm going, in this particular case, on the temporal side of the lens, or at least I made an attempt to first, but I'd rather go on the same side as my main incision. So that would be on a right eye, inferior nasal. It would be on a left eye, inferior nasal. In a left eye, it would be superior nasal. That's more comfortable to me, to go around it on the right side of the IOL, slightly slide the IOL to the left, and get the viscoelastic out from behind it. But remember, it's sort of just a nudging it out of the way. And once you get behind the IOL, you want the port of your IA pointed directly up, and that's going to be a safe position to not grab posterior capsule. And you want to rock it side to side a little bit, but usually most of the viscoelastic is already removed just by rotating in the anterior chamber. And at this point, I floor it on top of the IOL. I go behind the IOL, and I'm a little more careful then, because the posterior capsule, we have to be conscious of it when we're back there. So now I'll talk through these last two cases as they're happening. So here we're removing the viscoelastic in the anterior chamber. We want to rock with the IA tip. You want to be careful not to engage iris, especially if you have a floppy iris case. You want to keep it dead centered. Keep that port pointed straight up at you, but rock back and forth a little. So we're nudging the lens out of the way. We're lifting up after we get behind it. Now we're sliding it back into position just by touching it in the center, pushing down slightly, and then we can achieve recentration. Okay, we'll talk through it as it happens. We're filling the anterior chamber some. Now we're pointing posterior. We're never stopping the injection because we don't want to have the ability to go through the posterior capsule. We want a fluid wave in front of the IA tip, or the cannula tip. Okay, now we're going bevel up. I think that protects the endothelium some to go bevel up also. It also prevents the need to use a second instrument and torquing on our paracentesis wound. As the lens goes in and we start to distort the capsular bag complex some, we're pulling out. Now we're putting the trailing haptic in with the conner. We're pushing straight down, freeing up the haptics. If they won't get completely free and they're stubborn and stuck to the anterior surface of the IOL, get the utrotas out. You can just gently grab them with the utrotas. They'll open up. Okay, now we're doing IA in the anterior chamber, getting the provis out from there, rocking back and forth. We're going to nudge the lens over, get in behind it, and lift up with the port facing up so we don't grab posterior capsule. A little more washout in the anterior chamber. And we're going to come out quick so that we don't burp the anterior chamber and end up with a pressure of 0. Usually at this point our wounds are fairly tight. And so if you come out fairly quick, I don't mean jerk it out, but it should be a smooth motion, and it should be quick enough to where you don't burp all of your BSS out of the anterior chamber. That is ideal. This is a patient actually with Sturge-Weber who has an inferior hemangioma in the conj, interestingly enough. Okay, lens goes in. As it was being injected, we start to pull out so we don't distort the capsular bag complex, free up the haptics. Now we're getting ready to wash the anterior chamber. And the haptics pointed temporal and nasal are ideal for sliding the lens over and getting behind it. If you have a toric, that may not be possible. I usually start with my toric about 30 degrees counterclockwise from where I want it to end up. But think about where you're putting those haptics so that it's easy to get behind the lens. We nudge it out of the way. We lift up. Make it easy on yourself. Now we're putting the lens back in position, rocking in the anterior chamber. This is full foot pedal. I've got it floored now, maximum IA. And now watch, we're going to come out quick so the chamber doesn't collapse. And thanks for watching.